also a trainer, coach. I'm also a trainer, coach, and mentor. The project director for the Older Adult Behavioral Health Initiative, of which both Angela Franklin and Jensen are a part of. I'm the PASA Level 2 state coordinator for serious mental illness, and I'm also the geriatric behavioral health echo champion at OHA. So my training is really a much longer training, but today I'm just going to go right to the slums just because we only have an hour. And so I'm not really going to talk a lot about cognitive domains. That's a whole different training, and I'm happy to come back. But I'm really going to look at how do you administer this tool and how do you understand the results, and then work on applying it for your client. Okay? So really what we are going to look at is how can I understand what is the functional baseline of my client in terms of cognition after I do the slums. As you know, remaining in one's own home or living in an integrated care setting in the community or aging in place continues to be a primary goal for most older adults and for most of your clients. The capacity for safe and independent living, which is often threatened by, say, functional, behavioral health, physiological impairments, increasingly puts people at risk of can they continue to live independently? Should I be looking at different kinds of services and supports? And so the main kind of areas we look at, all of us, on this call, are what I call ADLs and IADLs, are very important as we age for us to live independently or near independently. ADLs, which are activities of daily living, ensure that people have their basic needs met, like eating, going to the toilet, having a shower, being able to get into bed and sleep. While instrumental activities of daily living, which is IADLs, help a person stay connected, live life meaningful, and support a much higher quality of life, and requires greater, what I call cognitive bandwidth, for them to really do those kind of higher level independent living skills. Someone hasn't muted themselves, so I'm hearing a sound. So if you don't mind muting yourself, I'd appreciate that very much. So with that backdrop, I want to just show you the cognitive domains before we kind of dive into what is this screening instrument. Here are the cognitive domains that slums actually evaluates. Look at it: learning and memory, language, attention, judgment, reasoning, speed of processing, perceptual motor, your ability to make decisions, plan, have working memory, respond to feedback and change your behavior or activity, inhibition, like putting the brakes on your behavior, mental flexibility, task initiation, that means being able to start a task, and also task perseverance, being able to stick with the task, even though you may face some barriers or obstacles or you don't feel like doing it. Organization and regulation. This is all part of cognition. And, all of us use these skills seamlessly. They're so integrated, correct? I'm not going to sit and say, oh, here I'm doing attention now or speed of processing. They're totally integrated in our everyday lives. Even for you all to show up today for this meeting, did you know you used all of these cognitive skills to be here today on time for this meeting? Now imagine if one of your clients has deficits in any of these areas, and how are you going to find that out? Which area they are have strengths in, and which are the areas where they're going to need supports and services. And that's where the slums comes in. Okay. So with that said, this is how the St. Louis University Mental Status Exam looks like. You all, I'm hoping many of you have a hard copy on your desk, if not a digital copy, perhaps on your second screen or on your tablet. So this is the slums. Okay, so just at the very beginning, it is important to put the demographics at the top of the page. And we always recommend that you write your name as the evaluator at the bottom. If you have any credentials, you're welcome to put them, and the date. Hopefully, it is done in a somewhat private setting, not just for confidentiality, but because you want the least amount of distractions, like noise, people walking by, or telephones, ringing. So hopefully it's in a private space, and you would need a watch with a second hand. Very important to record the number of years the client has attended school, whether it's 12th grade or 2 years of community college or 4-year undergraduate degree, whatever the case is, or 8th grade. Very important to put that add that in the demographics section. And then one caveat: please be aware that the person should be able to engage with you in this process. You may want to comment on how they're appearing, whether they seem very drowsy or confused or distracted, but they need to be somewhat alert to engage with you. I always get the question, should we do it in the emergency room? Should we do it in an acute psychiatric hospital? No, you shouldn't do it in an emergency room, and you shouldn't do it on the first day when they come into acute psych hospital, because that's not the best time. And so you may not get the best results. When someone is stressed, they are transitioned to a new living place. So choose your time carefully. Okay. So here is the slums. You have, all those questions on the paper that you have in front of you. This is what those questions are measuring. So number 1, 2, and 3 is orientation. Because guess what? In neurocognitive disorders, your orientation to time, place, people, etc., can get messed up or compromised, or you lose it. So that's what those questions are measuring. Number 4, 7, and 11 are actually measuring short-term memory and recall. So memory. Number 6 says naming of animals, so it's measuring your cognitive language ability. Number 5 and 8 is like mental calculations. Number 9 is a clock drawing. And number 10 is a recognition of geometrical figures and sizes. So those are the questions on that sheet of paper. Now look at how it is weighed or weighted. Remember, this is a 11 question test with 30 points, 30. 5 points are linked to attention and concentration. 5. 13 points to verbal memory, your ability to, for verbal memory. 5 points to visual, spatial, or construction abilities, which are, the clock and those diagrams. 4 points to language, and 3 points to orientation. So that is how this test is weighted, and And so now I'm just going to dive right into the test. So question 5 and 8 on the slums is, what is it looking at? Calculation, something called working memory, concentration, and attention. So I'm going to read out the question, and I'm hoping some of you will unmute yourselves and tell me the answer. You have $100 and you go to the store to buy a dozen apples for $3 and a tricycle for $20. How much did you spend? How much do you have left? Anyone wants to tell me the answers for both? You can just unmute yourself.
A question about that, Nirmala.
Yes.
Does it have to be in our minds, or can people
No,
down?
mental. Yeah, in your mind.
Oh God. Okay.
Here you are all seeing it, there you're reading it. So
people can't use a scratch paper and calculate it out.
No. It's mental.
So
anyone?
I think we spent $46. That would leave us with $54.
Okay, you spent $23.
No, 46.
No, I'm telling you the answer. It's 23. Oh. You remember you spent 20 for a tricycle and 3 for apples. Subtract that from 100.
Oh, I was thinking it was $3 for each apple.
No. So you bought a dozen apples for $3 and tricycle for 20. So, you spent $23. How much do you have left? 77. Louisa, everything is mental. Nothing your client is not writing it on a scratch pad or pulling out his iPhone and pulling out the calculator. No. So as you can see, this test is looking at calculation. How are you calculating this mentally? And working memory. Working memory is where you're able to remember these facts in your head for a short time. $100, $3 apples, $20 tricycle, and I have to subtract it.
Well, you have to. It's also about following instructions, and I did the same thing. I was thinking it was $3 an apple, which is, I can't do that in my head.
Yeah. So you need to. That's what working memory is. You're keeping it in your head and doing the mental arithmetic. And very important, attention and concentration. If you have attentional problems, like people in ADHD or anyone else who's distracted, guess what? You would not have understood my question. You would not have had key pieces of information. Oh, how much was the apple? What? There was a tricycle? Because you weren't paying attention, which is a core cognitive domain, is attention and concentration. So can you see, it seems such a simple test, but that's what it is measuring. And it says don't prompt or give hints, but give ample time for them to answer. Ample time doesn't mean 30 minutes. Ample time means 2 minutes, 3 minutes, you can give them, okay, to answer the question. If they ask you to repeat it, you can repeat it one time. You can't repeat the question repeatedly, okay? Now the next question, number 8, I'm going to give you a series of numbers, and I would like you to give them to me backwards. For example, if I say 42, by the way, you shouldn't say 42. You need to say each digit. For example, if I say 42, I would like you to say 24. If I say 87, so you should say 87. Okay, so here are the numbers: 87, 648, 8537. What did you notice? The numbers are growing bigger, right? First it's 2 digits, then it's 3 digits, then it's 4 digits. Remember, the person cannot see this. I have it up on my screen, so you are reading the number. You are only reading it to them, so it is absolutely audio only for them. And they have to say back, if you say 87, they have to say 78. If you say 8537, they have to say 7358. Now, can you see how it is measuring working memory? Because those numbers have to stick in your head, correct, for you to repeat them backwards. You have to really concentrate and pay attention to me. Otherwise, you won't register those numbers. So this is what these 2 questions are assessing.
Are they allowed to ask us to repeat it? So like I thought it was just one time.
Yes, one time only. Yes. Attention is your brain function. For attention, that is so important. Allocates processing resources for you to focus on that information that I'm giving you. It deals with how you mentally process information. And so attention is fundamental to our survival. Did you know that? It is one of the top cognitive, cognitive skills is attention. So absolutely how important attention was in these 2 questions. Working memory, you need that to stick those small informations in your head to actually act on it. So all of this is what those 2 questions measure. Here is what working memory is. It's temporary storage. For example, you're driving, someone calls you and gives you a phone number and wants them to call you back. That you have to memorize that number in your head and dial it. That is working memory. It needs focused attention. It is very important for school performance. And you can actually strengthen it. Now, number 6 is measuring language. And what is number 6? Please name as many animals as you can in 1 minute. Now, I'd like you all to unmute yourselves. And as soon as I tell you go, I'd like you all to start naming animals and I'll tell you to stop, okay? 1, 2, 3, go. Cat.
Zebra,
Giraffe,
cat,
Elephant, cat, dog,
tiger,
bird,
leopard,
camel,
tiger,
cow,
lion,
goose,
possum,
horse,
deer,
goat,
Squirrel,
Anteater.
mountain
fox,
lion,
coyote,
leopard, cheetah.
Hippopotamus, rhinoceros.
lion.
Okay, you can stop. It's not as easy as you think, but this is a very important question. What is being assessed here is cognitive language and verbal fluency, memory, and executive function. So the test says how many animals did you name? 0 to 4, 5 to 9, 10 to 14, or 15 plus. But that's what it is measuring. Cognitive language. So verbal fluency is the ability to name as many words of a given category. We chose animals. And this kind of verbal fluency test is an integral part of all neuropsychological test batteries. And for the diagnosis of dementia, which is neurocognitive disorder. And how well you perform on this question reflects integrity of the semantic system. That is the system responsible for storage of words and their association. Remember, the association was animals, and the storage was all of the names of those animals which you were able to bring up. It also does inhibition, self-monitoring. It inhibits you from your mind from wandering, so you're focused on animals. Self-monitoring, am I only seeing animals once, or am I, duplicating them? So can you see, it's really measuring a whole lot of different different cognitive domains, but most importantly, verbal fluency. And the principle is the lower the score, that means the fewer animals you were able to say, indicates concern. Did you know that some of the earliest signs of neurocognitive disorder is not memory problems, but it is language problem? What we call word finding difficulty, that they have very hard problem with words. And so this is often a standalone test. And it is used widely in neuropsychology and in neuropsychological testing, okay? So they are called just verbal fluency tests, VFTs for short. So there can be, yes.
Sorry, Nirmala, is this also used, like, say, people who have had strokes?
It
to
is,
kind of see how well they're coming back or improving?
Yes, it is, yes, yes. So there is something called letter fluency, which is, the other test is we tell you name objects with the letter A. That is more difficult. So that is called letter fluency. And the other one is called, what we did was animal was categorical or semantic fluency. So there are two kinds of tests. The one that SLUMS does is categorical or semantic fluency. What is the long and the short of it is that in conditions like dementia, individuals often show greater impairment in categorical fluency, like the one we just did, compared to letter fluency, indicating a deficit in memory and language areas. So this is what you are testing. Principle, lower the score, the greater the concern. That means in terms of how many animals they were able to tell you. So I will let you all read more if you're interested in more in-depth about letter and category fluency. Now we are moving to 9 and 10. Question number 9 and 10. What does that measure? As you can see, 9 is a clock drawing and 10 are, those three geometrical shapes. So the clock drawing actually measures something we called executive functioning, which kind of resides in the front of your head, in the frontal lobe. And it covers all of those complex cognitive skills like planning, problem solving, multitasking, initiating, inhibition, that clock drawing. And then the three geometrical designs, where you have to choose one, is really looking at whether what your eye see is being interpreted correctly by your brain, visuospatial. That gets impaired in dementia. So those are the two things that questions 9 and 10 are looking at. Okay, so you can, the instructions for 9 is you can either give them the full circle, which is available, you can download that, or you can ask them to draw a circle on the back of this form, and then tell them to put in the numbers, for the clock, and then ask them to show the time 11:10. And what you're scoring on is whether the numbers were put correctly. And especially 12, 3, 6, 9 are in the correct place. And that they have shown a longhand and a shorthand for the minute and hour hand. That is how you score it. Okay. So here I'm telling you, is the correct spacing, even spacing between the numbers? Is the placement of 3, 6, 9, 12 correct? Is the placement of the clock hands correct? And by the way, clock drawing is also a standalone test, like verbal fluency. It's a short screening test. Look at the drawings here. If you look at the bottom one here, the blank one, the middle one is someone who has no impairment, and then look at the one with the impairment. These are actual drawings. someone put those lines for numbers even outside the frame of the clock. Look at the other drawings. The numbers are crunched. One circle has numbers missing. One doesn't have the hands. The time is written outside the clock. As you can see, it tells you a lot. And look at the skills that are being measured here. Visual memory, visual spatial abilities, like how you are spacing the numbers, orientation and conceptualization of time, executive function, auditory comprehension because you're giving them instructions, correct? And understanding language, inhibition and by moving all distracting stimuli, frustration tolerance. All of this one test is measuring. And therefore, it is a standalone quick cognitive screening tool. This clock drawing has some advantages over some other tests because it doesn't rely on verbal abilities. And someone asked me about stroke. It is very good for patients with aphasia or other loss of verbal expressions, say through a stroke. It is also useful for non-English speaking populations. This standalone test, okay? And then there's number 10, which are those three geometrical, figures. What is that looking at? It is looking at visual spatial processing, which is the ability of your client to process visual stimuli and to comprehend spatial relationships between the object and what their brain is interpreting. So what does this help people with? Finding their orientation in space through taking in information from the world around them, then organizing that information in their brain, and then creating patterns so that they can function in the world. It happens seamlessly for us, but when you have a problem, it's not so seamless. Okay, so it's essentially how you see images and how you are perceiving, how your brain is using that information to help you function in the real world. That is what that question is. So what happens when people have problems in this area?
Nirmala, to let you know, it's 9:30.
Okay, thank you. So in real life, when what your eyes see and your brain is not interpreting well, you may miss the chair when you're going to sit down because your brain and your eyes are not in sync. Hey, that's the chair. It's really far, so don't sit. You need to get closer. It's not working. You get lost in familiar places. How many of you know that people with dementia wander? And wandering is considered an emergency in people with dementia because of this kind of visual spatial impairment. I had driving or parking difficulties. You were able to park really well in the garage, but suddenly your family is noting you have scratches on the side of your car because you're not seeing where the wall of the garage is. Your brain is not, accurately judging that spatial, that spatial difference that you need to know. Dressing apraxia. You don't know what clothing items go on first. For example, I still remember many years ago, we were doing an assessment on a woman for dementia. She used to come in really beautifully dressed, and we had a hunch that her sister was dressing her up. So we asked her to remove her her sneakers with socks. She was wearing socks and sneakers. And then we told her, can you put them back on? And she took the socks and put them on her hand instead of her foot. She had no awareness. This perceptual dysfunction was highly impaired. So she had what we called was dressing apraxia. So this is how it will show up in your clients. You know, they'll have difficulty driving. They may have difficulty recognizing faces and locating objects. They may be at risk of wandering off and getting lost, even in familiar areas, you know. Depth perception is impaired, so they may be at risk of falling. So lots of things that this question is assessing. Okay, then we have question 4, 7, and 11, which are all around kind of memory. So this is how you would ask them. Please remember these 5 objects. I will ask you what they are later. Apple, pen, tie, house, car. And it's good to ask them to repeat it, so you're sure they heard you right and, you know, they know the 5 words, okay? So, and you can repeat them as many times as it takes for them to repeat it back to you correctly. Now, if it's ongoing, you know, after 10 minutes, you're still repeating it, then there's a problem, you know. But if you repeat it 3 times, it's perfectly fine. So it's apple, pen, tie, house, car. And then you ask them, can you please repeat it back? Here we are looking at registration. Are these words registering with the person, and are they, like, you know, storing it someplace? Then you do some other questions, and then you come back on question 7 and ask, what were the 5 objects I asked you to remember? What we are assessing here is recall or retrieval. And you give 1 point for each correct word. The words were apple, pen, tie, house, car. So if they say all 5, he gets 5 out of 5. And in your note, you would say perfect recall, you know, 5 out of 5. So here you're doing retrieval and recall in number 7. Number 11 is really that little story that you read out to them, you know, and then you ask them a number of questions. You begin by saying, I'm going to tell you a story. Please listen carefully, because you want them to exercise really good attention. Because afterwards, I'm going to ask you some questions about it. Do not repeat the story. Watch to see if they are paying attention, and give plenty of time for answers. So you don't repeat the story. You only read it once. I would suggest reading it at an average pace, not very fast, and not really, really slow, but, you know, not just like an average pace, and be sure that they, you know, they can hear you well, and watch, are they paying attention? So you don't repeat the story. And then there's a whole bunch of questions that are asked, which are also really assessing memory, which is registration, short-term memory, retrieval, recall, that story too. This is how memory works. I love this diagram. It's a filing cabinet. Can you see input? What do you need? You need really good attention and concentration. So you're giving them the 5 words, correct? They need to go into that first drawer. That's where learning occurs. Okay, I now know the 5 words. Then you shut the cabinet and you've stored it. That is retention. I know the 5 words. I've stored it now very carefully in this filing cabinet. And then when I come back and ask you, hey, what were those 5 words? You pull the drawer out and you retrieve those words and you recall the words. That is output. This is how memory works. Now, can you imagine, you know, I talk about memory and learning going together. If you don't have memory, how can you learn, correct? If Louisa, you had memory problems, you would not remember the words I asked you to. You would be able to, you may be able to kind of learn them in the first go, but you're unable to store them. And you certainly are not able to retrieve them. Now, imagine if you're teaching them some skill in therapy. You want them to go and practice, say, cognitive errors. I want you to identify these errors. Here are 10 of them. And they can't remember what you said to them. How are they going to actually use those skills when they go home? And it's very easy to write in a note when they come back that they didn't do anything. They didn't do the homework. Well, it could be because they don't have memory. And maybe I need to do something else. So this is how memory impairment impacts instrumental activities of daily, asking the same question over and over again, getting lost in places, or you don't know the person well, having trouble following recipes or directions. You give them directions of doing something and they can't follow it. Becoming confused about time, place, and people. Not taking care of oneself. Not being able to manage complex chronic illnesses and medications. Because you need to have pretty big bandwidth for memory and learning to do that. And you can see how quickly someone can be at risk. So once you do the test, then you add up all the numbers that you've given, for each of the questions, and you come up with a total score. Anyone wants to tell me why we have two columns? There's one set of scores for high school education or higher, and then there's another set of score for less than high school education. That means your education level is below 12th grade. Why do we have these two different columns for the score? Anyone wants to just unmute yourselves? You can just take a guess. Education is protective of neurocognitive disorders. So the higher your education, you more likely can compensate for early deficits. And so what we do is we adjust the score for your level of education. Okay, so as you can see, people with a higher education, they have a higher cutoff for dementia, even though it's a point here and there, than people with a lower educational level. So yes, higher education is a protective factor for dementia. Many people ask me, Nirmala, how do we reduce our risk for dementia? I mean, that is one of the protective factors. And so if you can see normal, that means if you have a score of 27 for people who have a higher education, that is normal. 25 for someone with below high school education. For mild dementia, 21 or 20. Between 21 and 26, between 20 and 24. And then for having more moderate to severe dementia, it is 20 for people with higher education and 19 for people with less than high school education. So very important to adjust the score for level of education. That's why we want you to write that on the top of the test. So how does this all add up? John has an 18/30. Can he cook safely? Can he live alone in his apartment? Will he wander off and get lost? How much care does he need? Janet has very poor memory scores, but she uses lists and can still take her medication on time. What other supports do I need to put in place based on her slump score? So this is what I want you to use, to use the slumps for. Looking at, hey, where do they have the highest deficits? Is it memory? Is it language? I told you how those points are weighted. You know now what they are measuring. What services do I need to put in place? Here are critical skills for independent living. Shopping, getting groceries, being able to use transportation, preparing a meal. And when I say preparing a meal, I mean use of appliance, safe storage of food, cleaning of utensils, all of that, okay? Managing medications and other complex medical equipment like oxygen or maybe wound care or a CPAP machine, using phone or maybe a laptop to get help. How do you maintain your home so it is safe for you to stay in there? Keeping your appointments, managing your everyday finances like paying your bills on time or having a budget. All of that requires huge amounts of cognition. And all of these are affected by cognitive decline, which the slums is measuring. You can see here, maintaining a job. If you can't pay attention, you have no working memory, it's kind of difficult to maintain a job unless someone is building the supports for you around the job, correct? Keeping a clean and safe home, paying, shopping and having a budget, paying bills. These all seem like so simple to us, right? But they can be a huge endeavor for people with cognitive compromise. And here is how you use it every day, all of us. I know when to fill my prescriptions. I do mail order. I have a system where I know when I'm down to about 15, I call and order my pills because I have the bandwidth to do all of that, cognitive bandwidth. Yeah, preparing a meal is not just preparing the meal. It is budgeting, buying the appropriate items, knowing how to safely use the appliance, knowing how to clean up after you, knowing how to safely store food that is left over. Can you see it is multitask? It's not just preparing a meal. And how do you problem solve in an emergency when you don't have, say, heat in the home? These are good questions to ask your client, The door to your home is locked and you do not have a key. You want to see their problem-solving ability. You run out of medication that you take regularly. Like, the thing is, what will you do? You are at home and suddenly there's a fire in your kitchen. You notice that the cut on your foot is not healing and actually has become infected. The unsaid thing is, what will you do? Someone calls you saying you won $100,000 and they're asking you for your social security number. You're driving to the grocery store and you get a flat tire. Your heating unit breaks down and it is very cold outside. So these are really good questions to ask about problem solving and executive function, which is what you need for everyday living. Okay, so what happens when you have neurocognitive disorder? They affect your ADLs and your IADLs, which is what you want to know. How safe is it for my client to live in the community or participate in driving or work or whatever. So these would be all the issues that would be affected. Okay, so the challenges are, if we are not doing a thorough evaluation, they could be at risk of abuse, neglect, exploitation, and even death. They may lack understanding of their health and safety needs. They may be so unstable that they are permanently on the verge of losing their housing and are at risk of homelessness. So any of you who make referrals to aging and people with disabilities for your clients, this is what they look at in terms of cognition, self-preservation. Can your client keep themselves healthy and safe? Do they have enough language wherewithal to communicate? Can they make decisions in their best interest that will keep them safe and healthy? And are they clear of any kind of challenging behaviors that are coming due to a dementia? Okay, so my quick question to you today is there anything new that you learned today, and how will you change your practice from what we discussed today, aside from actually doing the St. Louis University Mental Status Exam? I'd love to know. Here is my contact information, and you're welcome to contact me directly, but I am going to just open it up. We have 10 minutes for any questions, comments, or anything else.
Okay, Louisa, jump in there. I know you've had your hand up for a bit.
Can you speak to people that try to navigate around this? You know that they're trying to overcompensate, trying to hide that their things are slipping. What are you seeing with that?
You know, that happens often. They did a recent survey of older adults, and they asked, what illness are you most afraid of? And everyone thought they would say cancer, but they said dementia. And it was like, the bar was like 4 times high. And then next was cancer, which was like, way down at the bottom. So lots of people are afraid of dementia. And when you said, they overcompensate or they hide, if they are doing that, I would still say it is in the milder stages, if they're able to do that. So, as it progresses, it will be family members who will be observing and letting you know that there's something wrong, or you as a clinician or a case manager on your team who's noticing things are different. So if you're still able to kind of hide and compensate, I would say it's still in the very early stages. And, people are feeling threatened. It's a disease, like I said, nobody wants.
So can you speak to how you provide the interpretation to the client? The client has gone through this process and then they say, well, how'd I do?
Right.
How does the clinician respond?
Best first phase to always acknowledge, I'm so grateful. I'm really thrilled that you're here today, that you did the test. Here is the good news. And then go over if there are any positives. It seems like you have very good memory and this and that. However, I have some concerns in some areas that it seems like, you may be having some problems with expressing yourself, with language. Or so you'd first always talk about the positive if there are some strengths in the test, and then talk about here are some areas of concern. Many people want to know, do I have dementia? Based on the score, and so I always say this is a screening instrument. It indicates you may have some problems in these areas. We would really like to do a more thorough exam. So any of you who are, it seems like all of you are going to be doing the slums. If it comes back as, a mild or moderate dementia, your team should then follow up with more in-depth assessments. For example, there are a whole bunch of labs that we recommend that your prescriber asks for to rule out any kind of what we call reversible causes of dementia. For example, one biggie is B12. If you have B12 deficiency, you may do very poorly on memory tasks, etc. So there are some lab tests that we recommend. So this is the first step in doing it, and then really having that team approach. Hey, what do we do next? How much more can we do to confirm this diagnosis?
Nirmala, how often is it recommended to run these tests if you're working with an individual who's already determined to have mild cognitive decline? How often are we?
I would say
addressed?
once in 6 months, not more than that. Because the decline is not like this precipitous, like every week it's going down. No.
Okay.
6 months, 12 months. So yeah, because this is not dementia is not like rapidly progressive.
Thank you.
Yeah.
So what this has brought forward is another gap that we need to address at a higher level in options is protocols. What is the response
Right.
after this assessment has been done based on what you
Absolutely.
get back?
Right.
And I think that's something that we need to figure out and get to you all fairly quickly, whether or
Yes.
not results go to your team lead and then it's staffed in a team meeting, or if it gets bumped in another direction. So we'll work on this piece, gang. We're just now rolling this out. You're going to help
So
us
it's
find more
almost
of the
like a
gaps.
decision tree, as a decision tree. There is a very good decision tree, both the Angelas, which if I forget to, please remind me to send you, which you can look at some decision trees, from large organizations to see if that is something you all can adapt or adopt. So
Great. Definitely.
absolutely. Yeah. Any other question? I'm hoping now you know really what each question is assessing. That was really my intention in terms of my objectives, so that you as clinicians, case managers, anyone else who works with older adults will understand, hey, question number 2 is doing this. Question number 3, the clock drawing is doing this. The animal naming, this is what it's looking at. I didn't give you the part on what is cognition, because that's a whole different training. And, if the Angela, Franklin, and Jensen want me to come back and you all want that training, that really goes over all of these, kind of these cognitive domains, and then also talks about what are some adaptations that you should do in terms of your practice for people who may have a neurocognitive disorder.
Great. And we had a question about materials. Yes, everyone will get the PowerPoint. Everyone will also get a copy of the SLU. Anything that Nirmala provides in her trainings, we always forward to our participants. Any other questions? We have 3 minutes left, and I know this was a down and dirty overview. Who else misinterpreted the math question? I mean, it's reasonable, $3 per apple. Yeah, you could misread that one. So it's good that we had a chance to really get each item explained, its intention and the domains that it's measuring.
Absolutely, yes. So thank you for inviting me. You can always ask any questions to both of the Angelas. I've given you my email on my PowerPoint. So if there's any other additional question, Angela, Jensen, you can
absolutely. We will
them
forward,
and send
if
them
we
to
can
me.
address, we'll forward
Yes.
it to you.
Absolutely. So thank you again for having me. If you'd like me to come back, to do the cognition piece, I would be very happy to. And I would encourage a small community of practice group where within options, you all are practicing the slums and understanding it better, to create a little small, maybe once a month a lunchtime meeting where you create this small community of practice. So, yeah.
That's a great idea.
Yeah.
That's a great idea. How many of you think you're going to be able to roll this out fairly easily and you're confident in using it? Everybody feel like this is doable? This is doable. Okay. We didn't lose anybody along the way. Nobody said, oh my God, you're making us do what? Okay, good. All right.
Yeah,
Stay
thank
strong,
you all.
everybody. Thank you again, and thank you, Nirmala. It's always a joy to learn from you.
Okay,
we will cut you loose. We give you the gift of time. 1 minute. Get to your next client. Run, Forrest, run.
Mhm.
Okay, and on that note, I'm gonna stop recording.